Today, we will be discussing about undernutrition-associated diabetes mellitus and its various aspects. We have with us Dr. Nihal Thomas, Head Center for Stem Cell Research, CMC Vellore. Welcome, sir. According to the research, undernutrition early in life is known to increase the risk of developing diabetes mellitus in adulthood. Some studies suggest that undernutrition during adulthood can lead to metabolic problem. So please elaborate and give some highlight about this and your research findings.
Good morning. Thank you, Dr. Anuba, for inviting me to this particular session. As you possibly have heard that more recently, the aspect of what was called malnutrition-related diabetes or malnutrition-modulated diabetes has been highlighted by the International Diabetes Federation as type 5 diabetes. And the reason for that is that this particular condition uh, was initially on the WHO classification way back in 1985. But owing to lack of adequate research, and of course, this disorder occurred more in developing countries, and at that time, facilities in developing countries across the world to perform such research being absent, the classification omitted it from the year 1998 onwards. Okay. So, having said that, in low income countries and low middle income countries across the world, this condition is still seen. Basically, we're talking about people who have a low BMI, who have diabetes, who tend to be young. This condition is different from other young forms of diabetes. The commonest form of young onset diabetes is type 1 diabetes, where they also tend to have a lowish BMI. So let me just give you some perspectives about definitions. So you have a BMI of less than 18.5, and the WHO says it's less than 18.5. You're defined as undernutrition or malnutrition. And there are certain other cutoffs. For example, the word lean, according to one Lancet article, in South Asians is a BMI less than 19.2. So lean does not mean not fat. Lean means, for me, at least from our definition, very lean. So people who are lean, who have diabetes of young onset, but not particularly common in children, but they tend to occur usually in late adolescence, after the age of 15, usually before the age of 30, but they can occur later also, after 40 or so. Mm-hmm. So this condition was first reported way back in 1955 in Jamaica and was called J-type diabetes. And subsequently, there were reports from East Pakistan before it got independence and became Bangladesh way back in 1961. And that was a very large series reported by Dr. Muhammad Ibrahim, one of the pioneers for diabetic care and research in East Pakistan at that time. And it was reported all over the sub-Saharan Africa in particular, and other parts of Asia, including India. So young persons, largely between the age groups of 18 to 30, but sometimes more than that. But despite not having insulin, they may require insulin, they wouldn't go into a crisis. So if you stop insulin in a patient with type 1 diabetes, they can develop what is called diabetic ketoacidosis, a condition which makes them very sick. Okay. They have massive weight loss, large amounts of urine, and they develop breathing difficulty in addition. So these patients are ketosis resistant. They do not develop this problem of ketoacidosis. Mm-hmm. Okay. Moreover, of course, there is usually no family history. It's a sporadic condition. So it's not one of those inherited forms of diabetes. You might have heard of what is called MODY, maturity onset diabetes in the young, wherein 50% of the offspring get this condition when they're young. Mm-hmm. So it's not like that as well. Mm-hmm. So these are the basic characteristics of this particular condition, which I'm highlighting over here. Mm-hmm. So why has it kind of taken importance on the center stage at this point of time? From the year 2010 onwards, there have been several epidemiological reports from Africa, particularly Uganda and Ethiopia. There's been a large review of the literature by one group from Rwanda, and there have also been reports coming in from the original place where it had its onset, that is Jamaica.
Mm.
So these are more credible because tests have been done to rule out other forms of diabetes. And these tests were not easily available 40 years ago in low income countries. So, with this in mind, our institute, that is Christian Medical College Vellore, and the endocrine department, which I belong to, collaborated with the Albert Einstein Medical College in New York. And my colleague, Professor Meredith Hawkins, and we kind of worked together. We had been doing, rather, our department in endocrinology had previously done state of the art studies to study people with low birth weight.
Mm.
But for this particular thing, we started collaborating with the Albert Einstein to enhance the experiments, the quality experiments even further. Now, what our experiments showed, and we did something called clamp studies, wherein you give large infusions of insulin and you give glucose at the same time, and you control the glucose levels at 90 milligram per deciliter for several hours. It's a very intense, difficult procedure. So when this is done, depending on the amount of insulin you give, you can figure out whether a person is resistant to insulin or not. And what we found is that they were not resistant to insulin.
Mm.
They were very sensitive to insulin. Point one. Point two, when we gave them what we called a mixed meal challenge test, we found they were deficient in insulin. So they're not resistant to insulin, but they are deficient in insulin. But the degree of deficiency was not as severe as type 1 diabetes, but it was fairly significant.
Okay.
The third thing which we found is when we gave them a load of isotope labeled glucose, the liver used to produce a large amount of glucose in type 2 diabetes.
Okay.
But it didn't happen in as to this extent in patients with this lean form of diabetes.
Mm-hmm.
So these are the three major factors. Besides this, we use a DEXA scan, which is the same device which you use to check osteoporosis, to check the total body fat.
Mm-hmm.
And we found their total body fat was extremely low, less than 20% of the total body mass in all of them. In contrast to patients with type 2 who had percentages more than 30 or 40%, and in type 1s who had a low percentage body fat but not as low as this particular condition.
Mm-hmm.
We use something called NMR spectroscopy using an MRI machine, and we measure the micro quantities of fat in the liver and in the muscle. And what we found was the quantum of fat in the liver was extremely low. So, in contrast to type 2 diabetes, where they have different grades of what we call fatty liver, grade 1, grade 2, grade 3. So, it's not present in these patients. In fact, it was so low that in a percentage it was not detectable in these patients. So, these are the salient physiological findings, and we, in this experiment, which took almost 7 years, why? Because it was very extensive and we did all these tests. We did the genetics to rule out body beta cell dysfunction, that's the cell that produces insulin. We did the genetics to rule out the resistance genes, which can cause severe insulin resistance. There are inherited conditions which can cause that.
Mm-hmm.
We did energy expenditure studies using calorimetry. So a whole bunch of tests was actually done in these patients, and that's why it took a long time. Now, we also compared them versus an equal number of type 1s, type 1 diabetes, type 2 diabetes, lean normal people, and obese normal people.
Mm-hmm.
So you can see over there that we are actually comparing five groups of subjects, and so we have the variables for. And this was published in uh, the American Diabetes Association flagship journal called Diabetes Care
Mm.
in the year 2022.
Okay.
So those are the physiological characteristics of this particular condition.
Right.
And after that, it attained highlight. It was given a process of highlighting when people wrote a review in Scientific American in 2023.
Mm.
And from then onwards, we have actually been working quite hard to kind of get people together from across the world to understand this condition. We had a consensus meeting in January this year, 2025, wherein 40 international experts and several national experts met together in Vellore and are coming out. A paper will be out in the next month or so
Okay.
in Lancet Global Health, talking about this condition in greater detail. And there's a recent publication in Physiology 2025, the flagship journal of the American Society of Physiology, published a month back, which also talks about this condition.
Right, sir.
So
So,
those are the developments.
hmm.
Type 5, the name came up in the recent IDF, the International Diabetes Federation meeting in Bangkok, when Peter Schwartz, the president of the International Diabetes Federation, gave it that label. And the reason for that was because in Germany, type 4 diabetes is diabetes in pregnancy. So he said, let's call this type 5. And by giving it such a name, you reduce stigmatization. You're not committing yourself towards saying this is the classification, but would any patient want to be called and say, you have malnutrition modulated diabetes, and then say, I have malnutrition modulated? It won't happen. I don't think a lot of physicians would like to call the patients like malnutrition modulated diabetes. So it gives an opportunity for a more neutral perspective to start looking at this condition. And there may be other factors other than undernutrition which may be responsible. For example, you have a vast number of people who have undernutrition who don't develop diabetes. So why is it that this group of people develop it?
Hmm.
There may be reasons which we don't fully understand, and these need to be looked at.
Right. So, what do current findings reveal about the pathophysiological mechanism driving insulin deficiency in UADM patients? Is it primarily due to pancreatic beta cell dysfunction or other mechanisms?
Yeah. So as I just mentioned to you,
Hmm.
pancreatic beta cell dysfunction or lack of insulin production is the major factor
Hmm.
over here. The other factors like insulin resistance is not a factor. Increased hepatic glucose output is not a factor. So it is largely, and the fact is, why does this happen? Perhaps you might like to understand that.
Hmm.
So during the phase of development of the fetus inside the mother's womb, if they are exposed to undernutrition, either outside the body, as in they don't have enough food insecurity, which could be due to either extreme low socioeconomic conditions in some rural parts of India, extreme may not be true all across the country, but in some rural parts of the country, certainly in some parts of sub-Saharan Africa, other parts of Asia, and any place where there's an ongoing war. Because you can see how clearly now that during the time of prolonged war, there's a lot of displacement, and the first people to be seriously affected are actually women and children.
Hmm.
So you can perceive someone who's pregnant during this particular point of time, and this poor nutrition, the first thing that becomes a casualty is protein intake.
Okay. Right.
Because even organizations which provide aid in war-torn zones, they would have to give bulk. And that would largely be in a lot of carbohydrates. Protein in general is probably less, maybe more expensive,
Mm.
difficult to provide. So, so the exogenous, the external undernutrition. There's also something I would like to say is probably endogenous undernutrition. For example, if I have high blood pressure and I become pregnant, and in the first trimester of pregnancy, the blood vessels to the placenta, the organ which feeds the baby, can become vasoconstricted. Supply to the placenta is less. Therefore, the baby is kind of underfed, even though the mother may be even obese.
Mhm.
So that is a relative undernutrition for the baby. Now we
Okay.
see a lot of in even in developed countries, you may see a lot of low birth weight babies because people in neonatal intensive care units in developed countries are increasingly having babies which are smaller and smaller 1.3, 1.2, 1 kilogram,
Oh, okay.
28 weeks delivery,
Mhm.
and they're surviving.
Mm.
So, this antenatal undernutrition is there. But that's only the first point. If you have antenatal undernutrition, but later in childhood and in adolescence, you have normal or overnutrition, you can develop obesity, hypertension, and type 2 diabetes.
Okay.
This is called the thrifty phenotype hypothesis.
Mhm.
Because as a fetus or as a newborn baby, I've adapted to a state of undernutrition. And if you give me adequate food or too much of food, I will start storing it in my body. Fat depots will increase, insulin resistance will increase,
Mhm.
and you will end up, there will be a little bit of pancreatic underdevelopment. The beta cells that produce insulin may be also effective.
Mm.
But these patients develop type 2 diabetes, hypertension, obesity, and maybe even cardiovascular disease later on in life.
Mhm. Okay.
That's type 2. But envisage a situation that after delivery, I am exposed to a very poor environment in terms of food intake, right? And because of this very poor food intake, I have continued undernutrition as a child, as an adolescent. That lack of undernutrition, and particularly if it is a lack of protein intake, can lead to worsening of the beta cell function, the insulin producing cells in the pancreas.
Okay.
And they can develop the insulin deficient kind of diabetes, which we have
Mm.
just talked about.
Mm. Right. So, is there a controversial finding that undernutrition is highly prevalent in LMICs such as Ethiopia? However, most individuals with undernutrition don't develop diabetes. So, can you elaborate and can you highlight about this?
Yeah, that's a good point. I mean, that's an excellent point. Um, we would say what percentage would be difficult to actually say, but a vast majority. And the first thing is, what is the degree of undernutrition in that particular region or that particular part of the country which it occurs? So we are for example, if where I'm living in Tamil Nadu, the higher GDP state, I don't think there's a significant degree of undernutrition in childhood in the vast majority of people. Sporadically, there may be some incidental cases of poverty where this may be happening, or some social reason where there's deprivation of protein intake. But in a place where it is more endemic, it is more prevalent that there's a lot of protein deficiency in the community. The prevalences of this condition may be higher. And this is seen much more in places like remote areas of sub-Saharan Africa, etc., which have been reported to much greater numbers.
Mm.
Now, why some people develop it and some don't, we are not sure of the exact reason. And I am not willing to hypothesize or predict as to why the reason is, because I certainly it could be the degree of protein deficiency, but there may be other factors in micronutrients which we are unaware of. There may be some other environmental factor which we are also unaware of. Unaware of.
Okay.
So,
So, sir, can you elaborate on the role of epigenetic changes such as DNA methylation caused by early life undernutrition in the development of UADM?
So, in uh, inside the uterus, the fetus, when exposed to undernutrition, there are various genes which lead to the normal development of stages of every cell in the body. It's a very complex biological phenomena which occurs, and each cell goes through development, and as each cell develops, each organ develops. So, if you're exposed to lack of proper nutrition or undernutrition or protein intake, the normal DNA, this code for developing proteins in the body may be affected. This could be affected due to chemical reactions, which include that of what we just discussed, demethylation and histone formation, which ultimately leads to
Hmm.
abnormal protein production or underproduction of proteins in the body, and therefore leading to organs which do not function normally, like the beta cell may not produce as much of insulin as required. The peripheral organs, the muscles, may not take up as much glucose as they expected to take up. So, all this can actually lead to a combination of factors due to epigenetic changes. And epigenesis is an ongoing phenomenon. It can occur in utero, it can occur in response to environmental toxins in adolescents or in adults as well. So, that phenomena is thought to be responsible for the abnormal production of insulin by the beta cells.
Right. So, what are the biggest research gaps right now in understanding UADM?
So it has always been a big predicament
Hmm.
that there are regions in the world which have this condition, but the same regions don't have the technology to investigate it. Now, we were very fortunate that we had the technology to investigate it and we had patients to look at. In Tamil Nadu, perhaps we didn't have big numbers, and that's why it took a long time to do the study, get proper informed consent, where these studies are very intense, take a lot of time of the patients, blood drawing, so a lot of time is consumed. Of course, we try to take care of the patients to the best of our abilities while doing these studies. So, doing those studies are extremely laborious, time consuming, need a lot of manpower, need a lot of technology, and a lot of know how. All our people are trained,
Hmm.
and many of the expertise and training we have sent our staff abroad for that kind of training. So,
Hmm.
that kind of expertise may not be there in, say, a country in sub Saharan Africa, which makes that is the biggest gap, wherein disease burden is high in a particular area, but the scientific ability to investigate is not there. That is the now after globalization, we are in a situation and also wherein there are countries which can do both. Like in India, in our center, we can do and we do have subjects. So that is the biggest thing. And because invest doing research in this area, even when the burden of the disease is high in a particular part of the country, they don't have necessarily the know-how to look at the disease and to prove it. The diagnosis of this undernutrition form of diabetes or type 5 diabetes is made as a diagnosis of exclusion.
Hmm.
So to rule out type 1 diabetes, which means you need the antibodies to measure the blood type.
Hmm.
You need to rule out pancreatic diabetes, a condition where the pancreas is small and has calcium stones inside it,
Hmm.
which means you need to do imaging of the pancreas. You can do an ultrasound that can visit sometimes, so it's better to do a CT scan. You need to rule out monogenic or MODI forms of diabetes. So you need to have state-of-the-art next generation sequencing, genetic testing as well.
Okay.
You need to look at body composition by doing DEXA scans or bioimpedance. So all these tests at under one roof are not necessarily available in many places, in developing countries or least developed countries, as we would call them,
Mm.
across the world. That's a
Right.
big challenge.
Mhm.
Having said that, we have to give formulae wherein people can think about this condition from a clinical perspective, have a set of criteria wherein people would start thinking about the condition.
Mm.
So that is important. And I think you might ask, what are the kinds of situations where you think about this condition more
Mm.
often? So, as I mentioned, the age of onset, young onset,
Mm.
generally coming from a rural area, generally belonging to a poor socioeconomic status, with a history of childhood malnutrition. The lack of a family history, the absence of ketoacidosis, the complication which occurs in type 1 diabetes, low C peptide levels, which is the prohormone of insulin, which is produced in the fasting state and also has a surge after you give a meal.
Right.
So if it's low, and the commonest antibody which is used for measuring in type 1 diabetes called the GAD65 antibody,
Mhm.
glutamic acid decarboxylase antibody. A history of low birth weight is very important. And what we have actually been asking our trainees at the Christian Medical College in Vellore
Mm.
is that when you have a young person with diabetes, please ask them what their birth weight is.
Okay.
And if they don't know it, ask them, pick up your cell phone and call your mother and find out what your birth weight is. It sounds a little funny, but this is a very important part of the history that we need
Mm.
to check in on.
Right.
There are certain features of insulin resistance. There's this velvety black thing which occurs around the neck and flexural areas called acanthosis nigricans. It's a marker of insulin resistance.
Mm.
Now, it will not happen in these patients with type 5 diabetes because they are not insulin resistant. And then the ultrasound of the pancreas to rule out calcium deficits,
Mm.
and maybe a DEXA to look at body fat, but that's not mandated over there. So the three tests which are required after you take a good history and apply the clinical criteria means C-peptide measurements, GAD65 antibodies, and an ultrasound or a CT scan of the pancreas to rule out pancreatic disease. These are the three tests which are a must, and I think can be done in most low middle income and middle income countries across the
Okay. You mentioned criteria for identifying UADM, but sir, are there any promising genetic, biochemical, or pathological markers that differentiate it from other diabetes types?
So you need to use a combination of tests, as I mentioned. There's no single test
Mm.
which will help in identifying the difference, right? So, like as I mentioned, beta cell function is deficient, so C peptides will be low. You need to take a good history, right? The history is very important. Like I said, low birth weight, low socioeconomic status, um, low protein intake in childhood and adolescence. So it's a combination of a good history, assessment of beta cell function, ruling out pancreatic disease, ruling out type 1 diabetes. That's it. There's no single test. But for that matter, if you really look at it, there is no single test to say someone has type 2 diabetes,
Mhm.
really speaking. It's a matter of exclusion. Of course, type 2 diabetes is the commonest form of diabetes in an adult
Mm.
and in older people more than the age of 30. So when you look at it from that perspective, that's an epidemiological phenomena which is common, very endemic, and therefore it's a diagnosis. You exclude other conditions and say that all this is type 2 diabetes. Here you use the opposite strategy.
Mm.
You exclude other conditions and then you say this is type 5 or malnutrition moderated diabetes. The
Okay.
only For type 1 diabetes, you have a definite biomarker, type 1,
Mm.
because they have the GAD antibodies, which are positive in early onset type 1. 70% may be positive for GAD1, and there are other antibodies, GAD65 antibodies.
Mhm.
So there is no single biomarker test for the so-called malnutrition related or undernutrition related or type 5 diabetes. But that's in itself is not a disqualifying factor to say that is it difficult to make a diagnosis. No, that's not the case.
Hmm. Right. So, do you believe undernutrition associated diabetes should be classified as a distinctive type of diabetes by the WHO, or is it more accurately a subtype of T1D or T2D? What are the strongest argument supporting its distinctions?
It's a very good question. I mean, that actually is a question which leads to scientific discussion, broad perspective of understanding of disease. And more than to the layman, this is an important question that we need to understand from the medical community perspective. It is almost certainly not a subtype of type 1 diabetes. Certainly not. Because type 1 diabetes is a condition which is prone for ketoacidosis, has low C peptides, and also has antibody positivity, which is specific for type 1 diabetes. Right? Okay. Now, is it a subtype of type 2 diabetes? And therein lies the problem. What is type 2 diabetes? And if you look at any textbook, if you look at even the WHO classification, type 2 diabetes does not have clear-cut diagnostic criteria by itself. We talk about people who are generally overweight, who are older, as in more than 30 years in general, though you can get younger people with type 2 diabetes. And if you do check their C peptides in the early phase, they are elevated, indicating good beta cell function but insulin resistance. But type 2 diabetes by itself is also a very complex disease with other factors. Some beta cell dysfunction in some people, hepatic glucose being increased, stress factors, the brain and how it might control the pancreas, the muscle and how the glucose uptake may be defective. So it's a complex disease, and I think it goes beyond the scope of the discussion to talk so much about type 2 diabetes. Now, there are people who say that people who have lower BMIs, 20, 21, could also have type 2 diabetes. And that these people do have some beta cell insulin producing defects. Now, the problem here is, are we including patients who have a distinctive type 1 diabetes and misclassifying them as type 2? People more recently have invented a cluster classification in the last 10 years. Now, all this is scientific clusters. It's not part of WHO or the American Diabetes Association or any of those criteria as yet. But it's trying to understand that type 2 has various subtypes. There is one subtype called SIDD, severe insulin deficient diabetes. Now, if you look at the Indian studies which have looked at SIDD, they do not have C peptides as low as what we see in type 5 diabetes. By and large, there is a standard deviation, there is a range. And maybe a few might fall into that category, but not really. Most of them don't. The median BMI in the SIDD studies from India, from South India, is around 23, 24. It's not as low as 19 or 18. So from what we can see, that particular subtype where you call so-called severe insulin deficient diabetes, and I have a problem with that terminology as severe because it's not that severe. When you actually look at the C peptide levels in most of them, it's not exactly the same as this condition. Now, could there be overlaps? Yes, there could be. There could be some subjects, but there could be a misclassification of this particular condition along with type. Now, you asked a very important question. Should this form, should type 5, should it be back in the WHO classification? Well, that's a very major decision. The WHO, if you look at the classification of types of diabetes, and I'll give one example. the inherited beta cell function, the MODY, maturity onset diabetes of the young. There are 14 types of MODY which have been reported in literature. Now, all those 14 don't come in the WHO classification. WHO makes a decision after a lot of discussion and deliberation to put something into a classification. They look at how common a disorder is or how relevant it is to the community. For me, I think this is a relevant thing and should be on the WHO classification. But it's not my own mandate. It's a group of people who need to discuss, decide, and that may take time, may take years to make that decision because these guidelines for the WHO come up once in, half a decade or once in a decade. So it may take time for ever that to happen as well. Individual societies, the American Diabetes Association in America, the EU in Europe have their own ways of looking at things, and they could perhaps subclassify. But this is a disease, a disorder, which is represented largely in the global south, in sub-Saharan Africa, in parts of Asia, some parts of Central America, Jamaica, West Indies, but is not seemingly a problem in the global north, in the developed world, so-called developed world. So would they prioritize to put it in their classification? I don't know. WHO should, possibly. That is my opinion. We need committees, discussions, and people who need to look forward and think about whether it should come there. I think it should, but let that happen in its own due time.
Right, right. Thank you, sir. Thank you for this insightful information. And in the end, I just like you to share your concluding note where you can mention anything specific or anything important you like to mention, please.
So I think perhaps one more thing which is important to mention is how do you treat the disease? And that is one very important point from a primary care physician to understand. Unlike type 1 diabetes eventually in 100% you need insulin. And you need to give it sometimes more often than not 4 times a day. More complicated to treat. The good news is from the literature and what we have done in our own studies is that 50% of these patients, even though they have an insulin deficiency, it's a relative deficiency, and 50% of them do not need insulin for treatment. They can be managed with oral, with tablets in 50%. The remaining 50% do not necessarily need 4 times a day insulin. They can be managed perhaps twice a day insulin. They are not prone for episodes of what we call ketoacidosis when you stop insulin for a few days. So some of them don't need insulin and they need to be trained and taught. The requirements of insulin, what we have seen, are low. And you have to be very careful that you don't give too much insulin because they are also prone for low sugars or hypoglycemia also occurring in this condition. It's also a very important thing that you need to understand. So treatment-wise, therapy-wise, very different from type 1 diabetes. And that is an important message for the community and also for the public health physician and the primary healthcare physician across the world.
Right, sir. Thank you so much. Thank you for your time. Thanks a lot.
You're most welcome.